Ready?
Yep.
Okay. So, hello everybody, and welcome to this week's clinical education webinar brought to you by the Merton Training Hub on behalf of the South West London Training Hubs. My name is Joanna Thorne. I'm a Merton GP and a Plan Care clinical lead at Merton CCG, as it was, and I'll be chairing the session. This is the fourth in the clinical education webinar series, which is set to hopefully be an ongoing weekly event for at least the next month. And next week's focus is on diabetes, just as your calendars. We've got an hour today to cover two areas, and so we're planning to take a few questions after Professor Baker's talk and then move on to Dr. Draper's talk. Actually, Professor Baker's done a little bit of work beforehand, so some of the questions might be answered in there, but actually we'll be trying to take questions through the chat function along the way. Everyone should automatically be muted, but please do double check and keep yourself on mute so we can avoid any background noises. And if your camera automatically comes on, please, we'd like to just see the speakers if that's okay. We are recording the session, and this will be shared via a private YouTube link through the South West London GP TeamNet as well. We'll also be using the chat function, as I said, on either the bottom or the side of your screen as the main way to ask questions. Please do feel free to ask questions or make comments throughout the webinar, but just for sort of ease, I'll be pulling out themes as to questions to put to our speakers, but at the end we're going to review the entire chat conversation and try and put together a kind of Q&A document in case there are any important areas or themes that have been missed. I know that we've also got some members of the medicines management team, and they're very helpful at popping on links and things, so do keep the chat open at the side of the screen so you can see the conversation. In terms of future webinars, please, if there are things that you think we should be focusing on, then do please pop the ideas on the chat function as well. Today we've got two excellent speakers from St George's. We've got Professor Emma Baker, who is a consultant in clinical pharmacology and general internal medicine with a particular interest in multimorbidity and polypharmacy. And then we've got Dr. Adrian Draper, a consultant in respiratory medicine with particular interest in lung cancer, where he's the clinical lead, and as well as occupational respiratory and interstitial lung disease. So we've got a first session about medication sick days and a case study. I hope some of you have had the opportunity to do some of the interactive work beforehand. And then we've got the second session is a bit more on respiratory focusing things of nebulizer use and respiratory exams over video consultations and COVID-19 specific things. So without further ado, I'm going to hand you over to Professor Baker. Are you there?
Hi Joe, thanks very much indeed, and thanks so much to be invited to this fantastic opportunity to speak to what seems like the whole of London, let alone South West. Thanks so much everybody for dialing in. I'm going to talk about sick day guidelines for usual medicines, and the reason I'm going to talk about this topic, apart from being a clinical pharmacologist, is because I've been writing a document on this with some GPs for NHS England. Is my microphone annoying, Joe? Is that okay? Is my sound okay? It's sort of funny this end.
No, it's fine, Emma. It's just I think there might be when people are logging on, it sometimes unmutes, but you're fine to go. We can hear you properly.
Okay, let me know if there's any problems. Thank you. So I've been writing this with some GPs in NHS England and some pharmacists, and so I've been getting quite interested in the topic, particularly around the time of COVID, when it's so much harder for our patients to access us as NHS professionals. Today I'm going to cover briefly the physiology and pharmacology of sick days. Those of you who feel that feels terribly like universities, hopefully it'll be interesting for a few minutes. I'm going to talk about some general principles for adjusting usual medicines and some most notable exceptions in terms of people and medicines. I sent out a pre-meeting case study, and at the time I looked, at least 71 people had done that, so thanks for doing that. And I'm going to look at your answers and try and answer all the questions and points you raised by giving me your answers, which won't leave much time for questions, but very happy to take them by email. So, sick days. Physiology. A sick day is basically when a patient gets acute illness that is sufficient to cause physiological stress. So if we look at the pathophysiology down the left of the slide, our patients we know have reduced oral intake, maybe can't swallow or take food and drink or tablets. They're losing fluid and electrolytes through vomiting, diarrhea and fever. This causes a release of stress hormones such as adrenaline, cortisol and glucagon, all of which increase insulin resistance. They may have systemic inflammation, which then activates coagulation pathways, and they may well have reduced immunity, particularly, for example, if they've got epithelial damage with viral infections. The consequences are shown down the right. We know that the dehydration can lead to renal impairment, reduced renal perfusion. The patients may get electrolyte disturbance, generally loss of sodium, potassium, chloride, etc. They get hyperglycemia because of the insulin resistance, and may get ketosis. Stress, particularly a very severe acute illness, can lead to peptic ulceration. They may get arterial thrombosis. For example, after a COPD exacerbation, your risk of a heart attack or stroke goes up. They may get venous thrombosis, deep vein thrombosis, or secondary bacterial infection. So sick days are a big stress on the body. Just let's look at COVID-19. How does that affect these things? Looking at various case series, about 40% of our patients with COVID are anorexic. About 18% have diarrhea. 99% have fever. Systemic inflammation is incredibly common, and so is activation of coagulation. 5% of people coming into hospital with normal kidneys have acute kidney injury, and 15% of those with prior chronic kidney disease. Electrolyte disturbance, both up and down, is very common, and COVID patients are very, very dehydrated, probably because of the high fever. Over 50% in hospital have hyperglycemia. Admittedly, these are hospital series, so they're probably less extensive in the community. And arterial venous thrombosis and secondary bacterial infection are important features. So now we've revised the physiology, let's revise the pharmacology. I'm not going to cover this in a lot of detail, but it's really important for us all to remember that the usual medicines are often the direct cause of the acute presentation. Again, with a hospitalist focus, 6.5% of acute hospital admissions are due to adverse drug reactions, and estimates are that 2/3 of those are preventable. And I guess that's partly why we're having these sick day guideline discussions. Patients on usual medicines are more likely to get acutely unwell, for example, if they're immunosuppressed. If they do get acutely unwell, they're more likely to be harmed. For example, if they're on nephrotoxic drugs, the DAM drugs that a lot of you have mentioned. Pharmacokinetics is disrupted by acute illness, reducing the benefits of medicines and increasing the risk. And you'll be delighted to know I'm going to give you a pharmacokinetics slide in a minute. And of course, any drugs that you're normally on might interact with those prescribed for acute illness, particularly, for example, antibiotics. A little PK slide for you, reminding you that drugs are absorbed, distributed, metabolized, and excreted, and the drug has to get to the target to have an effect. In acute illness, patients may not be able to take their medicines. If they've got GI upset, they may not absorb them, and they may get reduced plasma concentration with loss of efficacy and withdrawal reactions. They also, we've mentioned, may become dehydrated, get renal impairment, reduced drug clearance, which may increase the plasma concentration, increasing the risk of side effects and toxicity. So let's have a think about adjusting usual medicines on sick days. And this is, I think, an incredibly difficult topic. First question is, what is sick and how sick do you have to be to need to adjust your medicines? There's various definitions. So in general, it's suggested that things you should be worried about are things that cause dehydration. So if the patient has vomiting, diarrhea, fever, sweating and/or shaking sufficient to cause dehydration and/or to prevent them from taking or absorbing medicines, they should be considered sick enough for us to need to adjust their medicines. NHS Scotland attempted to imagine the patient trying to make sense of this. How much vomiting, etc. Please, can you mute your mic if you're not muted? NHS Scotland have described this as unless minor. So again, that's quite tricky. Another definition I found was 2 or more episodes. And in a way, I think the Addison's self-help website has a good definition of anything that makes you feel poorly or weak. So that's sort of how sick, but it's difficult to judge exactly when you need to adjust your medicines. So what are the general principles? As always with prescribing, it's not rocket science. And I'm sure you all do this far better than I do. Advising people to avoid dehydration, which seems to be the most important thing. And NHS advice to patients is to drink plenty of water so the pee is light yellow and clear. And of course, reduce fever by taking an antipyretic such as paracetamol. I've added into this, keep as mobile as possible. I'm imagining patients on HRT or on the pill who can't get up because they feel ill, who have a hypercoagulable state and acute illness. So I think keeping mobile is important for lots of reasons, but to reduce the risk of thrombosis. And in general, as a general principle, patients should continue all their usual medicines for long-term conditions at their usual doses to avoid those long-term conditions decompensating. That's the general principle. Except, with every rule comes exceptions. And I think these can be divided into people and drugs. I'm going to start by highlighting the 3 groups of patients on essential life-preserving medications where these drugs must not be stopped and probably need to be increased. So those with adrenal insufficiency who are on hydrocortisone or corticosteroids, those with diabetes insipidus on vasopressin, and those with diabetes mellitus on insulin. So those patients, we might need to increase the dose of their drugs. And then, of course, there are patients who are more at risk. So I suppose the green patients are at risk of harm from stopping, and the red patients are perhaps at more increased risk of harm from continuing. So if you have CKD, as we've seen in the COVID series, you're more likely to get an acute kidney injury if you become unwell. If you have diabetes on tablets, you're more likely to come to harm during acute illness from metabolic disturbance. And if you're immunosuppressed, you're more likely to get secondary infections or be at risk of an infection in the first place. Then exceptions, drugs. So again, there are these drugs that require a dose increase, steroids and insulin, and I'll cover steroids in more detail in the talk in the case series. And then there are drugs where we might want to stop them. And I've started with the DAM drugs, the ones that affect the kidneys, and the SGLT2 inhibitors and the immunosuppressants, because we have good guidance around those and we're going to cover them in our patient. And I've also thrown in antihypertensives for our frail elderly who are going to fall over, and bisphosphonates and iron for people who can't swallow, who are at risk of esophageal damage. I think, just to conclude this bit of the talk, before we get on to the case, that it is incredibly difficult. We're balancing up the risks of continuing the drug, which might increase the severity and complications of acute illness, against the risk of withholding the drug, losing disease control, generating withdrawal reactions. And if we tell our patients it doesn't matter if they don't take their drug for a bit, this might result in them not restarting them and then not sticking to their treatment regimen. It's complicated hugely by the fact that each patient will be different. They'll have a different set of underlying diagnoses and comorbidities. The symptom severity and duration of acute illness will be different every time, and so each time might need different adjustment of their medicines. The pharmacokinetics and the duration of the drug effect varies for every drug, as I'll show you in a little while. And so it's incredibly difficult. I think also the greater the risk of continuing the drug, the greater the risk of withholding. So, for example, a patient with mild hypertension on an ACE inhibitor and normal kidneys can probably safely stop the ACE inhibitor for a bit, but probably isn't the patient who needs to stop it because their kidneys are okay. Whereas the patient with severe heart failure on an ACE inhibitor is the one who will decompensate if you stop the ACE inhibitor, but also probably also has CKD and is the one who will get the side effects. So it's not easy, and it's not easy for us. Imagine how hard it is for those patients who actually spend 99.99% of the time self-managing and only a very small amount of time with us as health professionals. So having thoroughly depressed you as how hard it is, let's have a look at a case and see how we can apply the principles and exceptions to make this possible. So for those of you who haven't yet had a chance to look at the case, this lady is Mrs. Audrey Merton. For those of you from Richmond, Wandsworth, etc., I apologise, but I thought this was a Merton meeting, so she's a Merton patient. She's phoned up your GP practice asking for advice. She's feeling well at the moment, but she's asking for advice about what she should do if she gets COVID, because she's worried about it. You can see that she has underlying hypertension, type 2 diabetes mellitus, and rheumatoid arthritis, and she's on medicines for these conditions, as well as some for chronic pain, depression, insomnia. I've put them alphabetically as they usually come out. So the first question I asked you was, would you make any, when she rings up and she's well, would you make any changes to her usual medicines to reduce the risk of COVID-19? And thanks to those 73 people so far who have answered these live feed. And I just thought, when I read what you put, I thought, I'm so glad that as I get old and become a polypharmacy multi-morbid geriatric, I'm going to be looked after in Southwest London. So that was a great reassurance to me to see your answers. I've tried to, because I had to fix a point at which to try and make some answers to your questions. I tried to pull out some themes when you got to 53 people, but I think the themes are similar for the remaining 20 people who've joined. So there were about a third of people who said at this stage, when she's well, they wouldn't make any, so the first question was, would you make any changes to her medicine at this stage? And there are about a third of people who said no, they wouldn't make any changes. But of course, some people very appropriately pointed out that this lady should be shielding. For patients on immunosuppression, there's very helpful guidance that I'm sure most of you have seen now from NHS England. I've put the link in the slides, which I'm happy to be shared. And there's a table as to exactly what drugs you're on and exactly what precautions you need to take. And this is pulled out of that table. This is a lady who should shield because she's on a corticosteroid dose of more than 5 or more milligrams of prednisolone. And she's also on another immunosuppressive drug, methotrexate. So she should be shielding, and that's a very good advice from this person here. So a third of you thought we shouldn't do anything up front. A lot of you thought you would like to reduce the dose of steroids. And there's a really good discussion. Although you weren't discussing it with each other because you hadn't seen each other's answers, there were some really good points that you could pull together into a great MTDT discussion about this. Clearly, we need to know how long she's been on the steroids, and clearly it's about weaning down. Lots of people suggested looking in the clinic letters to see what the rheumatologist had said, which was a good idea, or trying to reduce it themselves. One person said they would stop the prednisolone. So let's just look at what the advice is from NICE and the NHS England. All of this has been done with the British Society for Rheumatology. The first thing that I think is really interesting to point out is that patients on immunosuppression may not present typically from COVID. We said that 99% of patients would have a fever, but patients on steroids may not develop a fever. So I think it's really important for us to remember that with our immunosuppressed patients. The second bit of advice, again, as pretty much everybody indicated in their answers, is that they wouldn't just stop the steroids because, of course, once you've been on them for a long time, you're at risk of adrenal suppression. If you've been on long-term steroids, it can take at least 12 months for you, up to 12 months for your adrenals to recover. And some patients who've been on the very long term may never recover adrenal function and may need to be on replacement. So we should definitely not stop them suddenly, even though there's a slight concerns about the risk of steroids and COVID. And I'm sure Adrian will touch on steroids a bit in a minute. The second thing people suggested was to try and reduce the dose. And again, this is NHS England advice to see if the dose can safely be reduced. It's probably worth mentioning at this point that a lot of the clinical trials are testing to see if steroids of any dose have any use in COVID disease, because we know it's both a viral infection and also the virus activates the immune system and it's an immune problem subsequently. So immunosuppression may actually be beneficial in some ways and for some patients with COVID. The second thing that people said was that they would optimize a diabetes. And I actually thought that was a very good answer. Although we have no evidence that optimizing long-term conditions improves outcomes from COVID, certainly having a long-term condition increases your risk, and having diabetes uncontrolled increases your risk of infection. So I thought that was a really good idea. Nobody, I was slightly surprised, pointed out that this diabetic lady wasn't on a statin, but I guess that might be something to think about. This was a good suggestion, I thought, was changing the dapagliflozin. So dapagliflozin, and we'll look at that in a minute about how many people thought to stop it, etc. What it is it's a drug that blocks a sugar transporter in the kidney called SGLT2. And so it increases urinary sugar excretion. The problem with the SGLT2 inhibitors is that there's an increased risk of diabetic ketoacidosis, which could be triggered, for example, by acute illness or COVID. The SGLT2 inhibitors also increase sugar excretion in the urine, so can drive dehydration. And again, as I pointed out, that's a key feature of COVID disease. The diabetic ketoacidosis with these drugs is unusual in that the sugar may be low, although the ketones are high, because it increases sugar excretion in the urine. One of the questions I was asked at the end of the presentation was, can you monitor ketones in the urine if you can't monitor it in the blood? And the answer is yes. It's better to measure them in the blood because it's more accurate, but you can measure them in the urine if you don't have the access to the blood tests. So changing DAPA, which is only an option for the treatment of type 2 diabetes, if the lady is stable and it's possible in these difficult COVID times, I thought was a good suggestion. If not, if she's stable and happy on it, she could continue on it, of course, but be warned to stop it if she does then develop COVID disease. I'm aware that I'm going to run out of time, so I'm going to rush on. I liked the people who wanted to try and get her off the CNS depressant drugs. Very important. Interestingly, respiratory depression doesn't really seem to be an issue in COVID. Everyone's puffing and panting away. Someone suggested gastroprotection for a patient on prednisolone and an SSRI. This showed fantastic awareness of the fact that both of these drugs can increase the risk of GI bleeding. However, the gastroprotection is only necessary if the patient is also on a non-steroidal anti-inflammatory or low-dose aspirin. So I asked you, if she becomes acutely unwell with COVID, should she withhold any of her medicines, the so-called sick day rules? What I thought was fascinating was that there's 60 people have answered this question to date, and somebody would have thought that each of the drugs she was on should have been withheld. I also asked you, should she increase the dose of any of her medicines? And you both, mostly you suggested steroids. About 2/3 of those who replied said increase the dose of prednisolone, and about 6 people said increase the dose of cocodamol. There's a couple of a few people wanted to increase her antidiabetics. I get that, she may be sugary, but there's also the risk of harm from these drugs. Again, it's a balance. So this is, as I said when I put the question out there, there is no right answer. These are my thoughts. I've put the things that you might want to withhold in orange because they potentially could cause more harm than good during the acute illness. I've put the things that you wouldn't want to stop in green or you might want to increase in green. And I've indicated my strength of feeling by the strength of the colour. And the dark orange, we definitely have guidance for. So the rheumatology NICE guidelines say that if somebody has got COVID disease or other infection, they should withhold their metformin during methotrexate, easy to make a mistake, methotrexate during the infection and consult their rheumatologist for advice on when to restart. We've seen that the SGLT2 inhibitors should be withheld because of the risk of ketoacidosis, and metformin for a possibly smaller but significant risk of lactic acidosis. The other drugs then get harder. So she shouldn't take bisphosphonates if she can't take a big drink of water and sit upright for 30 minutes because of esophageal damage. if she's a bit unwell, she could probably carry on her antihypertensives, but there's probably low harm from withholding them, but some benefit from withholding them. I think it'd be really important for this lady to uncouple her cocodamol so that she can take maximum dose of paracetamol and reduce her codeine. Codeine is metabolized to morphine, which is excreted by the kidneys, and so the renal doctors prefer tramadol for people who have chronic kidney disease, and maybe it'd be good if we could try and get her off those, or at least down as low as possible on those moderate opioids for chronic pain, which we know can do more harm than good. Although we'd love to get her off gabapentin and Z drugs and maybe reduce her SSRI, at the moment we shouldn't do anything because they can trigger withdrawal, and that can be quick. And then finally, we should increase the steroids. Now, the steroids is all around avoiding adrenal suppression, deficiency. Our adrenals make equivalent of around 7.5 milligrams of prednisolone a day. So the dose you want them on is above 7.5 milligrams, so 10 or 15 milligrams. If you're on 20 milligrams or 30 milligrams, you don't need to double that. You just need to be on enough so that you're on approximately twice of the normal adrenal dose amount. I'm running terribly out of time. So I asked you to rank the drugs from the fastest to slowest in terms of what would go wrong when she stopped them, in terms of loss of disease control and withdrawal. And what I thought was interesting is I think you actually rank them in terms of your worries rather than in terms of their pharmacological effect. So I would just leave you with the thought that the opioids and paracetamol will start to wear off in hours, and opioid withdrawal can start within hours. Gabapentin and Z drugs, you'll get withdrawal effects in hours to days. If you stop your diabetes drugs, you probably still have a few days before you go seriously hypoglycemic. Your SSRI, you might withdraw in 3 or 4 days. Your antihypertensives, your blood pressure will start to go up in days, maybe to weeks. You've probably got a bit of time. Methotrexate was one of the drugs you thought would be a problem early on, but we only take it weekly, and the immunosuppression may take weeks to wear off. And bisphosphonates bind to your bones and actually have a terminal half-life, which means the last molecule leaves your body. It takes 10 years. So you're okay. Oh, heavens, that's my phone. I shall mute myself.
And that's also half. That's all right.
That's fine. I'm finished. So lots of things to think about. It's incredibly difficult. I'll leave you with the thought that if it's hard for us, it's really hard for the patients. I'm in the process of trying to, I think I've answered most of the questions and comments. I'm going to leave you with these two, the COPD and asthma question, which I'm going to hand over to Dr. Draper, and the comment, which will scroll back up in a minute, was that if Audrey recovers, it would be a good opportunity for deprescribing, which indeed it would. So as a clinical pharmacologist, when COVID recedes, our ClinPharm team has been working with Merton to start developing some polypharmacy clinics for these most complex multimorbid patients. And hopefully we will be able to see some of your patients if you'd like us to. And please get in touch if you have any questions. Thanks for listening.
Brilliant. Thank you very much. Can we hand over swiftly? That was great. We didn't have any extra questions and really well understood. So we will, yes, get any other questions, do stick them up along the way. But let me hand over to Dr. Draper.
Thank you. Hopefully you can all hear me clearly. I'm just going to try and share my screen. I'll work out how to do that again. Share. There we go. Cool. Can everybody see the screen?
Yep, we can see it.
You got slides, yep, good, fine. So I can't work out on my laptop whether it's sharing, that's why. Let me just connect thing. Right, okay, so thanks everybody. Thank you for so many people logging in to join this webinar. It's fantastic. Having got used to using Microsoft Teams over the last couple of weeks, I can see there are real great benefits to this. The fact that everybody can sort of log in from their home or their office of work, and it's fantastic actually. It's not as sociable and friendly, but probably get more information out. Now, I was tasked to answer a few specific questions. What I thought I'd do is just do a talk around COVID and some of our experiences of it that we've seen in the hospital and some background to the disease. And having to follow an eloquent talk like Professor Baker has just done is always a bit difficult. And thankfully, by probably serendipity rather than design, we've managed not to overlap too much. We did have a discussion about that. And certainly, I agree with everything that Emma has said thus far. And it's interesting, when you were all asked about which drugs to stop, you all gave different answers. And it just shows if you ask 5 physicians the same question, you get 5 different answers. And that's the beauty of the art and science of medicine in uncertainty. Okay, so I want to talk to you a bit about the epidemiology of COVID as I understand it, the clinical manifestations of the disease, and then a bit on about the respiratory effects and who to shield and what we do with certain respiratory via video, which I will comment on one slide, and then just tell you what we've been doing locally at St George's for some of our patients. So without further ado, we know that the official name for the COVID is in fact SARS-CoV-2, just so we know that's the official title. And you can see, if I use my arrow here, the coronavirus under electron micrograph is called this because it looks like a crown. It's got this corona type effect. There have already been 6 identified coronaviruses in humans, which were first identified in the 1960s. And the latest one, the 7th, is a beta form, and it's a large RNA virus. And as we all know, this was first really recognised in around December 2019 in the city of Wuhan in the Hubei province of China. It has been linked to the seafood market there, and transmission from animals to humans is the thoughtful vector of how this virus has come out, although there's lots of conspiracy theories. Just to be aware, Wuhan has a population of about 11 million people, so it's bigger than London, about 10% bigger than London's population, so a very large place. The virus is transmitted by respiratory droplets, and you can see my horrible picture of somebody sneezing here, and I'll come on to the transmission in a second, what a droplet is. It has been detected in faeces, and it seems to persist in faeces, which has had an effect on why we're not doing colonoscopies and so forth at the moment, and not doing laparoscopic surgery on the abdomen. But interesting, it's not been found in sweat. Just talking a bit about aerosolization now. So droplets are defined as particles that are greater than 5 micrometers, and these will fall to the ground with the effect of gravity, and they'll therefore only travel less than a meter by definition. And they consist of cellular material from our airway, electrolytes from our airway, and then various bugs. And of course we generate these from breathing, talking, and particularly coughing and sneezing. And actually the surgical face masks are fairly useful in this situation to prevent us from actually spreading droplets, and also if you're wearing them and somebody coughs at you, the droplets won't get in. Droplet nuclei are particles of less than 5 microns. And these, sorry, I put there's an error there, it says fall to the ground, that's incorrect, that's because I did a copy, cut and paste. They don't fall to the ground, and they will travel greater than a meter. And they are generated by aerosol generating procedures. Now, I've listed a few, it's not comprehensive, but they're most of the relevant aerosol generating procedures as defined by the WHO. And if you're doing these, you need full protection. You can see a picture of me here about to do a bronchoscopy a couple of in full protection with gloves, gown, a proper FFP3 mask and a visor, and also head protection. Now it's interesting, the WHO have declared administration of nebulized treatment as a aerosol generating procedure, and also CPR as the Resuscitation Council. This is contrary to what PHE England have said. So Public Health England don't think administration of nebulized treatment is actually an aerosol generating procedure, and I'm actually inclined to agree with that, because we're talking about patient generated aerosols. So actually a nebulizer is actually an aerosol generated from a medicinal device with a drug in it, so it's actually not generating aerosol in the patient itself. So I think that probably isn't an aerosol generating procedure. CPR, I think, probably is. Anybody that's done CPR knows when you're jumping up and down on somebody's chest, actually, sometimes they expel contents from their mouth. So it probably does constitute an aerosol generating procedure for the sake of argument. And we should use appropriate protection when doing those procedures. But actually, when we've been working in the ward environment without aerosol generating procedures, we've been using gloves, aprons, and masks, such as the surgical masks. Now, what else do we know about the properties of the virus? We know it's killed by simple disinfectants, but not ingesting disinfectants such as Dettol, as suggested by Donald Trump earlier on in the month. I mean, I cannot believe that, but what chaos that gentleman sometimes causes. So definitely not ingestion, either injection or drinking, not a great idea. Now, I found a paper published in April on the sort of survivability of the virus. I thought it was quite interesting. I wanted to share some of this data with you. So Chin and colleagues in Hong Kong took 5 microliters of viral culture with the COVID virus and put it onto various media and surfaces, and then undertook measurements to see if it could be detected subsequently over a period of a couple of weeks. And you can see here they've incubated the virus at various temperatures. And you can see at fairly high temperatures, so 70 degrees or more boiling water is going to kill the virus pretty quickly, as does 56 degrees. But you can see body temperature and lower, actually the virus survives. So it does have a latency and can survive in the environment. Secondly, they also tested on different surfaces, and I think this is really interesting because you can see that paper and tissue paper, it really only survived for under an hour. Whereas if you look at some of the other media, it actually hangs around, certainly on money, for a couple of days, and then metal and plastic surfaces for half a week. And really rather interestingly and rather worryingly, on the inner and outer layers of masks, it survived for 7 days. And these were surgical masks. So surgical masks certainly need to be disposed of carefully when used in the clinical environment. And then they also looked at the effect of disinfectants, and we can see, as has been commonly thought, that all disinfectants work, and actually alcohol is particularly effective, and soap is perhaps the least effective of those, but all bleaches and disinfectants will clear the virus. And just another little thing they did, showing the virus actually survives various pHs, so it can survive quite an acidic and also an alkaline. It's all about the clinical manifestations we've been seeing in hospital, and I'm sure we've seen very different experience to what you may be seeing in the community. Certainly there are a lot of patients who are asymptomatic, and we think that for most patients who get this disease, it's a relatively minor illness. But the ones that certainly come to hospital have fever and cough, and even I'm sure many patients in the community have had this. And what we've noted is that breathlessness occurs certainly about a week into the illness, and the patients that were coming into hospital were exhibiting, a lot of them were exhibiting signs of what we call silent or happy hypoxia. So the patients will be sat actually reading their magazine or newspaper on the ward, looking perfectly well, and you stick a pulse oximeter on them and their sats are 81%. It was actually quite frightening. And many of these patients needed to go on to be ventilated, but not all of them. The other symptoms vary. So we've seen quite a bit of fatigue and perhaps myalgia. The amount of GI upset is not as much as perhaps reported in the literature. And anosmia, I think I've seen 1 case of it. Again, I think this may be more common in the community setting. In terms of blood tests, we certainly see when patients come into hospital and are unwell, they get at this immunological storm that Professor Baker mentioned earlier, and we often see a raised CRP, and in my experience most of the patients had CRPs of at least greater than 200, often 300. And virtually all the patients, when presenting acutely at the start of their illness, will present with a lymphopenia, and they crash their lymphocyte count. If measured, the ferritin and D dimer also seem to be elevated. Radiographically, the patients present with a pneumonic illness, which we can see both on the chest radiograph sometimes and certainly on CT scan. And they're often bilateral changes of peripheral ground glass nature, and I'll show you a couple of examples of that now. So here's a chest radiograph, and this I consider to be a fairly severe case of a patient that's hospitalised. And what you can see is there's just a general patchy abnormality in both lung fields, and that's a fairly severe radiographic case. Sometimes we see it just in the lower zones particularly, and sometimes it's more unilateral, and sometimes you can't see it at all on the chest radiograph. But I would expect this patient to have been fairly hypoxic. terms of CT, and this is a CT scan of a different patient and only one cut of the CT. So you can see this is the right lung and left lung, and here's the trachea, and you can just see a slightly collapsed esophagus here. And you can see there are ground glass changes peripherally through each lung, through this section, and there's a little bit of atelectatic thickening along actually this is the oblique fissure, I think. And that's a fairly typical COVID manifestation, and we've seen a lot of that in the last few weeks. So how do we make the diagnosis in the patient? Well, it's important, as always, to take a history and get a clinical diagnosis so that the clinical symptoms have to fit. And the patients will often say, present with the symptoms described, and on auscultation in the chest, you'll hear crackles at the lung bases is probably the commonest finding. The radiology should fit, and the biochemistry should hopefully fit. And then we have to prove the acute presence of the virus with the PCR on the nasopharyngeal swab that we've all been doing. In terms of assays, at the moment, in fact, they've just announced on the news today that I think Roche have had an assay tested at Porton Down, which actually looks is promising, I think, going to be rolled out. But certainly we've been doing a study at St George's, not me, I've been participating as a volunteer actually in giving blood, in measuring IgM to see acutely if there's presence of antibodies, and then IgA and IgG. And my understanding is the IgG is also looking promising to see if people have had a history of disease. And I think we'll hear more about that in the future, and it'll be very useful at some point in the future to be able to test everybody with a simple assay test to see if we've historically had the condition, because that will presumably confer us a period of immunity. I mean, we won't be at risk of future infection, but we don't know how long that immunity will last at the moment. In terms of treatment now, what have we been doing? So when patients come to the hospital, it's pretty much supportive treatment and mainly oxygen. We have, because nobody really knows whether any of the treatments work, we at St George's participated in the recovery trial, and across the UK, during the last 4 to 6 weeks, 7,000 patients have been recovered and recruited into the recovery trial, and they've been randomised to two arms of no treatment, and then there are 4 treatment arms with the antiretroviral drug, the lopinavir-ritonavir combination, which is a HIV drug, dexamethasone, hydroxychloroquine, and azithromycin, the macrolide antibiotic. There have also been some studies, not necessarily done at St George's, for remdesivir, which is an agent that was designed to treat Ebola, which is like a different virus. And then there's also been some studies using convalescent serum from patients who've recovered to give antibodies to try and help with the treatment. Many of the patients unfortunately got very unwell in hospital and required sedation and formal mechanical ventilation. And many of these patients had to be proned. A significant proportion required inotropic support and then renal replacement therapy. And these are the patients that seem to be having the really bad immune surge. And in fact, we've also been, as part of the recovery trial, patients can be randomized to tocilizumab, which is an anti-IL-6 treatment that's used in rheumatoid disease. And we've also been giving that compassionately to some patients with reasonable effects. That's another important treatment that's used in selected patients. Now, what are the risk factors? You've heard about this in the media, but certainly age is a risk factor in terms of risk factor of the severity of the disease and death. So certainly older patients seem to be sadly much more susceptible to this disease. The males are much more susceptible, and I didn't say, I think the intensive care mortality rate is approaching sort of 50%. It's pretty grim, and the males to female death rate is 2 to 1. And certainly ethnicity, being of black or Asian origin, seems to be a risk of having severe disease and death. And then many of the patients we've admitted have hypertension, diabetes, and obesity seems to be a risk factor. I've seen some data published about obesity saying it's a risk factor, although I have to say I wasn't that impressed by the data. I thought they looked pretty similar to me, but anyway, we will see in due course when more research comes out. The ICU patients have been pretty sick, but thankfully some of them have been discharged home, and my wonderful colleagues in ICU are arranging follow-up of these patients at 4 to 6 weeks. Because we know they've been suffering with, some of them suffer with myocarditis. There appears to be a vasculopathy in these patients with an increased tendency to venous thromboembolism and possibly strokes. And as I say, our ICU colleagues are following these patients up. With all of the other patients that didn't make it to ITU but have been admitted to hospital, my colleague, Dr. Ong, who's our care group lead, has set up essentially a telephone consultation clinic we've started running this week. In fact, I did my first one yesterday. So we've been contacting all the patients and going through a structured interview. And we have a plan and a pro forma that we're following in terms of follow-up. So if patients have ongoing symptoms that have been discharged, we will bring them back in and do further imaging. So you, as certainly for patients around the St George's cohort, you as GPs don't need to do anything about these patients immediately, because we are dealing with them and we will follow them all up as necessary. If they're well, we're discharging them, and we'll write you a letter informing you of what's happening to them. You may have some questions, of course, about patients that have not been in hospital, not to do with ongoing symptoms, and we will gladly offer some help for those too. And we will see patients face to face that are problematic after doing some relevant investigations. So there is a follow-up plan for all these patients over the next few weeks. Now, what about shielding and other risk factors? Now, what I can say, I think, is that respiratory disorders seem to have been underrepresented in terms of hospital admissions, particularly asthma and COPD. Now, I have seen patients, a lady with COPD I had sent to intensive care, and she sadly died. So I think some of these patients don't do well, and I don't know why they've been relatively underrepresented. It may be the effect of shielding, so the patients have shielded and just not got the disease. There is a hypothesis that maybe a lot of these patients are on inhaled steroids and that had a protective effect. Don't know. Or it might be these patients not biologically resistant, but just don't get affected as badly by coronavirus. We just don't know. I suspect it's a combination of all three, and I suspect actually shielding is probably part of the answers. I'm sure many of these patients know what it's like to have an exacerbation when they get a viral illness and just don't want to get it at all. But we've certainly seen an underrepresentation of airways disease in hospital. In terms of shielding, the Thoracic Society and NHS England have come up with a sort of strategy for that, and I'm sure you're probably all aware of this. So all of our patients with interstitial lung disease and sarcoid have been advised to shield. Patients with bronchiectasis, not CF related, have also been advised to shield if they are severe, and you can see in the smaller font there at the bottom what defines severity in bronchiectasis. Patients on long-term ventilation, our asthmatics who are on biologic injectable therapies have been told to shield. Milder asthmatics don't need to shield, they just follow the social distancing like the rest of the population. And patients with pulmonary hypertension are going to be vulnerable, and patients with severe COPD. And I think you can use the latter two things about exacerbation rates in bronchiectasis and airflow obstruction and so forth as applying to COPD as well as what constitutes severe COPD.
Can I just give you a 5-minute warning?
Yep, of course. I've only got a couple more slides actually. In terms of asthma and COPD, we are continuing to treat with I would suggest continuing treatment with steroid treatment. I wouldn't stop the treatment, because withdrawal treatment, you've already heard from Professor Baker about withdrawing drugs can cause problems, and actually withdrawing inhaled steroids from asthmatics and COPDs will probably cause them to exacerbate, and then they may end up in hospital and catch COVID that way, even those comally. So, or hopefully not, but possibly. So actually, I wouldn't advise stopping steroids at the moment. In terms of patients with sleep apnea, continue their CPAP at home. Being on CPAP doesn't increase your risk of actual COVID or make the COVID worse. It just creates a potential problem if you get COVID to actually aerosolizing. It's an aerosol generating procedure around your home. So if patients get symptoms of COVID, they have to self-isolate at home, and they have to make a local decision about whether to stop CPAP in case they give COVID to their family. Now, I was asked about respiratory video or respiratory examination by video consultation. I've rather hopefully comically put up, I just don't think it's possible. I mean, you can't examine somebody at the end of a video. However, you can see if they've got an audible wheeze, you can see if they're visibly dyspneic, and you can probably count their respiratory rate. So I think the remote consultations and video consultations are useful to follow up and talk to patients who are stable. I think new patients that are undiagnosed, and for example patients with lung cancer, need face-to-face consults still, and we are still offering face-to-face consultations certainly for patients with lung cancer, radiologically they've obviously got a lung cancer, and other sick people. We're still continuing to deal with life-threatening conditions. We're still seeing acute, new tuberculosis cases, and we will be moving on to other conditions shortly. And we're probably going to move our method of triage in the whole of St George's is going to change. We're going to have a referral system where we will triage patients appropriately to clinics on referral rather than just choose and book into any old clinic. And hopefully that'll be better for the patients and actually for us to control our service. Just so you're all aware, our AAA is still functioning and you can use that service. There's still a medical SPR on call, and there's a respiratory SPR on call during Monday to Friday during the working hours for specific advice. Kinesis is still running. There are 4 of us on Kinesis, myself, my respiratory nurse consultant colleague Sam, and then Nikki and Sasha, my 2 colleagues. I put what I do there. I'm either instantly reply or I don't reply. I take 3 or 4 days. I'm sorry, it depends how busy I am. My responses tend to be quite abrupt and direct, but hopefully they tell you what to do. And the IT infrastructure is pretty poor, so sometimes the whole thing crashes. If I don't respond, it's because the IT is crashing. 2 things I ask, please, if you put a request into Kinesis, put the patient's name on the request. Some people don't, or some of you don't, and just put an NHS number, and it just takes me ages trying to find out who the patient is. It is a secure system, allegedly, so therefore we can put the patient's name on. And secondly, if a patient's known to our clinic, please don't put Kinesis requests to me on it. I hate it. Please email the consultant, my colleague, direct, and they can answer about their patients. The reason I say that is because there are lots of us affiliated to the chest clinic now, and you can see us all there and what we do. I've put Professor Baker and Professor Jones in italic because they're now emeritus professors with regards to the chest clinic. But the rest of us are all available, and you can imagine if I get a Kinesis call about one of my colleagues' patients, I can't answer for all of them, so I'd rather you contact them directly. I know you're responsible, they should be on Kinesis, but I haven't managed to convince them that yet. So I'll stop there. Thank you.
Brilliant, thank you very much. We've had a couple of questions. One of them was actually, how can we find email addresses if you did want us to email directly?
Yeah, okay, I thought that'd be a question. Most of us will have an email address that's, our name with a dot between it at stgeorges.nhs.uk, so adrian.draper@stgeorges.nhs.uk, or the NHS net, if NHS mail. Now I'm trying to remember, not all of us use NHS mail, but if you go into the NHS directory, our name should appear on there actually, in the email, and we can use it. Yep. And if you don't have any joy with that, email me or Kinesis me, and I'll make them respond.
That sounds good. The only other question, there was one little debate that's been going on. There's been some things shared on the chat. One of them was around, is there any, I know there have been up in papers about it and the evidence might be a bit sketchy, but did you have a view on high dose zinc and vitamin D as a sort of prevention or treatment for COVID?
I haven't heard about that and haven't read about that, so I've no idea.
That's fine. I think there is some.
So the answer is I don't know. I'd need to go and look at the evidence. I mean, theoretically, anything's possible. I mean, vitamin D probably. I won't do of any evidence. Yeah, I'm sure there are no randomised trials of whether it works, but it probably wouldn't do any harm. Well, and as long as you haven't got sarcoid, for God's sakes, don't take vitamin D if you've got sarcoid, because you end up hypocalcemic, or any other. If you've got any other reason to be hypocalcemic, that's the only thing I would want to avoid it.
Very good. Okay, and then the other one was someone had popped up with so in the rescue medicine for COPD patients, are we still using that? And are we using the same dose if someone has COVID and there's COPD?
I think so, yes. I don't see any reason not to, actually. I think one should continue to treat patients normally. I don't know if Emma's still online. If she's got any contrary views on that, she's welcome to give a contrary view. But I think I would carry on as normal.
I think the things that I had read otherwise had been that if people have responded to that in the past, then do it, and if they haven't, then don't. If that makes sense.
Yeah.
Lovely. Well, I think we've got 4 minutes. 4 minutes left. There's a couple more questions now popping up.
Yep.
And so actually people are putting very helpful links on. So I just want to take the opportunity to say thank you so much to Professor Baker and Dr. Draper for those excellent presentations. I hope you saw that there were lots of thanks popping up on the chat as we were going along as well. I think there's been some really good things to think about, and as we've said, there will be a recording and the Q&A document will follow, and people have been linking in helpful bits and pieces of documents to look at and other things. I want to take this opportunity also to really thank Zero Safdar for all her hard work in getting these going on an ongoing basis and teaching people like me tech. Then for all those who registered via the Eventbrite and SurveyMonkey, a link will be sent for feedback and your certificate. But if you joined without registering and you want a certificate, please email Zero directly. And then just a reminder, same time next week, and the topic is on diabetes, and that's going to be chaired by Dr. Judy Roberts with Dr. Ronnie Saha appearing. We've had, I believe, over 200 people involved. So thank you very much, everyone, and thank you again to the speakers.
Thank you very much.
Thank you. Take care. Bye.